Hi, I'm Dr. Whitney Jones. I'm a gastroenterologist from Louisville, Kentucky, and a fierce colon cancer screening advocate for over 21 years. I'm the founder of the Colon Cancer Prevention Project, and I'm lucky at this time to be the chair of the state's Department of Public Health Kentucky Colorectal Cancer Screening and Prevention Program. I want to thank the Kentucky Hospital Association for giving me this opportunity to talk to you today about proper coding for colon cancer screening. And again, we're going to have a talk about this and we'll go from there. My disclosures are as follow. I have a consulting company called Upstream Health Strategies, and I'm a speaker for Grail LLC as well as a consultant. And I want to thank everyone at the KHA because in Kentucky, we have had nation-leading improvements in our colorectal cancer screening rates. I'll show you. Yet our cancer burden remains first in the nation because of extremely high incidence rate, which relate back to our high risk factors, smoking, obesity, lifestyle, sedentary behavior, etc. In Kentucky, of course, there's been a major shift over the last 2 decades where the majority of people who perform colonoscopies and where colonoscopies are performed are within Kentucky Hospital Association facilities. And so the majority of coders as well as endoscopists are pertinent to this discussion through KHA leadership in their organizations. Two major trends have been critical about why we need to have this discussion today. First is the very rapid rise of early age onset colorectal cancers in Kentucky and across the country. This is a critical role for people being identified who are earlier than 45 to be screened on time with colonoscopy. And so this is a really critical piece. Almost 20% of people who develop colon cancer are going to be under the age of 50, and it will be the number one cause of cancer-related death in people under the age of 50 by 2030. So finding these high-risk people, coding their colonoscopies correctly so they can feel like that barriers are lowered is really important. The second big piece is, with the advent of Cologuard and FIT testing and soon to be blood testing with Shield to detect A, colon cancer is often a two-step screening process, with the first step being either a stool test or a blood-based test, and when that's positive, to be followed by a completion colonoscopy. In other words, an essential part of the screening process, not a diagnostic colonoscopy in and of itself, because to be eligible for stool-based testing, you need to be asymptomatic and at average risk. So again, screening colonoscopies following a stool-based test is another critical piece that needs the right coding so that people aren't facing unnecessary cost, unnecessary barriers to care. One of the other things I'll discuss too is the incidental history collected prior to a screening colonoscopy. It's common for us to ask patients, have you had any diarrhea, anything else I need to know about? And often patients will say, yes, I've had a little blood now and then, or maybe I've had some diarrhea, but I'm mainly here for colon cancer screening. Those are incidental to the screening colonoscopy and should not change the intention of the scope itself. And finally, I want to say that waiving cost sharing is critical to compliance with all cancer screenings. We did some studies in 2016 that suggested almost $1 million of inappropriate cost sharing was happening in Kentucky across all of the USPSTF screenings. So this is a slide that really shows this amazing success. And again, KHA has really been part of this. They've been there with us all along in our process over the last 20 years. And first of all, in the green, I want to show you our screening rates. We've had a 40% increase in screening from 2000 to 2020, and that's amazing. So we screen it almost 75%, but as the age has been lowered from 50 to 45, that's going to drop significantly for all states across the country. This 45 to 49 range is a really critical piece because we want to get people engaged as soon as possible in screening. The second issue I want to point out too is incidence rate shown in the red. They have gone down approximately 30% from 2000 to 2020. And what that means is almost 650 people each year are not developing colon cancer because we are identifying and removing polyps. And that is the greatest, impetus of colon cancer screening is the fact that we can actually prevent colon cancer from happening. In the blue, you'll also see a significant reduction in mortality rates. Much of that comes from stage shift by identifying cancers that are asymptomatic in earlier stages that are easier to treat. Some of that's, of course, from improved chemotherapy. But again, about 250 people don't die because their cancers were found early or they were able to receive newer treatment. All in all, it's almost 1,000 Kentuckians each and every year who aren't facing death or colon cancer because of improvements in screening rates And this translates to about $64 million in cost savings annually for the state of Kentucky in terms of treatment costs. And I want to thank Dr. Tucker and the folks at the Kentucky Cancer Registry and Market Cancer for providing this great information and data. Now let's talk a little bit about Kentucky's colorectal cancer control priorities and Kentucky Hospital Association membership's central role in this. So here's 5 things on here. Number 1, we want to increase overall on-time colorectal cancer screening rates in those 45 to 79. And we really want to focus on this 45 to 49. We want people to get screened on time. That's when it works best. 45 is the finish line for communication about getting your first screening. It's not the starting point. Surveillance and further appropriate repetitive screenings are needed, but again, getting this started on time is really going to help us because the vast majority of people who get colon cancer under age 50 are in that 45 to 49 range. Number 2, we want to address proactively and pragmatically this rise in young colorectal cancer, of which Kentucky is the 3rd highest state in the nation in terms of incidence. And what that's going to mean is delivering information about colorectal cancer prevention, early detection, family history, as well as symptom presentation to all adults, just like women receive information about breast cancer and breast health throughout their life. And in addition, perhaps for another seminar, we'll talk about the importance of having prompt, complete evaluations, usually by colonoscopy, for signs and symptoms of sporadic colon cancer in people who are under the routine normal screening age of 45, including people in their 20s and 30s. Next, I want to talk about increasing the on-time high-risk screens at age 40. This is really going to happen at the primary care level where we take appropriate cancer family histories. People with advanced adenomas, strong histories of cancer ought to undergo earlier screening and potentially even genetic testing. And so that's very critical. Second, anyone developing colorectal cancer at any age in the state of Kentucky and across the nation, according to NCCN guidelines, should undergo microsatellite instability or mismatch repair staining of the tumor itself, as well as germline testing to determine whether this is hereditary. Kentucky is a founder's mutation location for Lynch syndrome, which is the most common colorectal cancer mutation affecting 1 out of 297 people. Next, we want to optimize this 2-step screening process. There's lots of room, and this is how screening is going to evolve in the future to involve these first-step processes to better triage those folks. A person with a positive stool-based test is 10 times more likely to have cancer than just a routine screening colonoscopy with no positive stool test. So this is very critical. So number 1, we want to improve compliance after completion colonoscopy. And we secondly want to reduce the wait times, and it should really be less than 2 months. Think about how long you'd want to wait if you had a positive stool test to get your colonoscopy. Waits above 3 months, I think, are unacceptable, and certainly we're seeing, unfortunately, some waits of 6 to 9 months across the nation, including here in Kentucky. But what we're going to talk about for the rest of the seminar is eliminating inappropriate cost sharing. And again, this means accurate billings for screenings with no cost sharing, and that includes for preparation as well. Low volume split dose preps are an integral part of colonoscopy and should be covered as the process. And unfortunately, many people are not getting that covered because it takes pre-authorization. It's a bit of a hassle for folks. That's another issue. But if you've had colonoscopies, then you'll understand the critical nature of the best prep possible. So we'll talk today about this, and the rest of the talk will be about cost sharing and proper coding and correct coding, as I've worked with many coders through the year in my own practice and our hospital. No cost sharing for screening services matters. Improper coding leads to improper cost sharing, and that discourages those who are at high risk to be screened. It often leads to incomplete screening. So a person with a positive stool test thinking that they're going to have to pay money out of pocket for a completion colonoscopy is a huge barrier. Many times they're asked to pay that the morning they go in for their colonoscopy, and it's quite a surprise, and it's inappropriate. Everyone has a financial burden and fear of a bill that's going to be thousands of dollars. And unfortunately, I think it leads to a distrust of medical systems, which discourages friends, families, and others that may be at high risk. One bad story affects 10 people, and so we all know that. So again, this is important. But there are huge benefits to correct coding, right? It'll help us address early age onset colon cancer by getting high-risk people screened and having that be a covered service, so we want them to come in. It'll also improve the impact of 2-step cancer screening, so after a positive stool test, the need for a colonoscopy. And also, it streamlines the billing cycle for hospitals by having correct coding that is paid by the payer without cost sharing or co-insurance, that claim is able to be pushed through appropriately and quickly and be paid. And again, at the overall piece, it encourages people to be screened across the space. So again, we don't want anyone to code incorrectly, but it is critical that we get to correct coding based on these new laws and these trends in colon cancer screening that we have the opportunity to implement in Kentucky. Just a little talk about the young colon cancer, and we've had a lot of people who call and complain to our organization that they're at risk for colon cancer from a genetic issue, but their doctors are charging them for the colonoscopy because they're high risk. Well, whether you're high risk or average risk, colon cancer screening should be covered in a colonoscopy. And this is why it's so important. In this study by Gupta, there were 2,473 patients with colon cancer under the age of 50. And about 25% of these people had met screening criteria for getting screened because of family history. And if we would have screened those 25%, 98% of the time, had we screened them on time, it would have been before the date they got diagnosed with cancer, meaning that we could have either potentially prevented that cancer by finding polyps or found that cancer at the earliest possible stage, giving that patient the best chance of survival. And so again, this is why it's so critical. And again, we know that risk-based on-time screening prevents colorectal cancer and colorectal cancer deaths, especially in the high risk. The other thing that's been a little hard, I think, for folks is we've had a lot of legislation in Kentucky over the past decade, all the way back to 2008 when the Kentucky Colon Cancer Screening Program was created, including in 2015 this KRS 304-17A to 247, when a screening colonoscopy, according to state statute, is to be coded as a screening regardless of what's found at the time of the colonoscopy. So you go in for a screening and people find polyps, diverticulosis, other things. Many times people were changing the code. So you'd go to sleep with anesthesia, with a screening, and wake up with a big bill. That's not right for anyone. And that was cured by us in 2015. That's also now national statute at the federal level. In addition, colonoscopies performed to complete a screening for a non-invasive stool test should be coded as a screening colonoscopy. And so Kentucky, I'm glad to say, was probably 6 years ahead of the nation in terms of pushing these, and I think that's a result of these great impacts we're having on morbidity, mortality, and screening rates in our state. So thank you guys for that. So here's 3 examples with the appropriate codes there that, again, we want to focus on today to take home. And again, I'd encourage you to share this with your coding department. Consider doing a quality or process improvement evaluation and audit from the time you implement education to your team. And we'll talk about the healthcare ecosystem and the coding ecosystem and who needs to be in that. But again, getting more people screened with lower barriers is really a goal that we should all have in cancer control. So here you see a coding family, and again, they're all going to be under the same coding family, which is screening colonoscopy. The risk, again, doesn't matter, average risk or high risk, or a person with a positive stool-based test. Again, are those 3 things that we've spoken about. For the first two, the first one, excuse me, they're almost always going to be over 45 and asymptomatic. For high-risk screenings, they're under 45, but they remain asymptomatic. Anyone coming in with significant rectal bleeding and pain and coming in with symptoms, that's a diagnostic colonoscopy. We're not trying to alter that at all, but many people with high risk in particular are getting screened as diagnostic and not as screening. And then finally, this positive stool-based test. All of these people who, in order to receive a stool-based test, are asymptomatic and over the age of 45. And so the correct coding indications are as follows on the right side. I won't go through those except to say that your coders will know those by heart. And again, these are the indications, but they all fit within the screening colonoscopy family. And we'll talk a little bit next about how that wording. And this wording is actually driven by providers. Providers are the ones who the coders look at their operative notes and use exactly what they've said. I think the entire coding ecosystem needs to be educated, but there's a critical role providers, and 90% of endoscopy providers are employed by Kentucky Hospital Association members. So here's the ecosystem. When a primary care doctor identifies a patient for screening, they're then referred for screening, and that word should be utilized and should be at the very front of each of these interactions. Once the scheduler gets that done, they're going to call the endoscopy unit. That's another chance to reinforce that this is a screening colonoscopy. And we'll talk about the ways to enhance that screening colonoscopy based on age, based on risk, or based on a positive stool test test. So in the endoscopy unit next, it's the provider's responsibility to document screening in the operative note. And we're going to encourage very strongly that the first indication for people who are appropriate screens in these three categories have screening colonoscopy as the first words out. And so the coder can actually look at that and know exactly what they're doing. The operative note is what coders utilize as well as billing information to do that. They then assign a code. That code is then submitted to the payer, and the payer makes the payment. And we've had many conversations with payers across the state who are very interested in paying for screening colonoscopies as they come in, because we know of all the cancer screenings, the only one that is both life-saving as well as cost-saving is colorectal cancer screening. So they are anxious to save money, funds, and treatment through this as well. So let's break this down a little more in a different way. So again, the scheduler, and again, having been in practice for almost 30 years, I feel like I know this pretty well. The scheduler first contacts the patient, figures out the screening, the prep instructions, and calls and makes that appointment with the appropriate screening endoscopy person. The endoscopy unit should also be confirming that the colonoscopy is a screening piece, because we don't want a disparate documentation from a facility fee from the professional fee, and we want to make sure those align. The providers are critically important in documenting the indication for screening. The word screening should be used as the #1 indication. Then, if there are any other symptoms, for instance, a person who had diarrhea wants the doctor ask him, the document should say screening colonoscopy, comma, there's incidental blood in the stool or diarrhea, etc. And that keeps the screening family code first, and these others is incidental. The second piece is you were screening for high risk. Again, what's the elevated risk? Colon cancer in a father with polyps or Lynch syndrome. Again, still a screening colonoscopy, but being performed in a person under the age of 45 because of elevated risks. So very important. And then finally, for this two-step process, the importance of using for completion screening after a positive stool test. That's either usually a FIT or a Cologuard, but in the future will be blood-based screenings as well. The coders then can correctly code for screening as documented by the provider with appropriate modifiers. And then payers get a clean code that comes through that can be paid in a relatively short turnaround. Again, I think to improve the revenue cycles for everyone. And again, whether it's an average risk, an elevated risk, or someone with a positive small bowel tube. And I want to really focus here. Don't forget the bowel prep. That bowel prep is an essential part of a colonoscopy, and there should be no cost sharing for low dose, split dose preps, which give the highest quality colonoscopy, and that's the ability to identify polyps or cancer as well.
Hi, I'm Jennifer Hutchinson. I am the Director of Coding for an acute care facility here in Kentucky. Thank you for taking the time to watch this recording on coding. It's very important that we code screening colonoscopies correctly, and it's written to KRS 304-117A257. Coders are always dedicated to accurate and compliant coding and billing. If the provider documents the procedure as a screening colonoscopy, we will code it correctly as documented. The provider is the main driver in documenting the appropriate indication for the procedure. This proper documentation helps ensure the accuracy of the codes assigned by the coders. As Dr. Jones implied, as well as guidance written in KRS 304-17A257, screening is the first indication when it's appropriate. Coders cannot assume the purpose of the procedure, and they must rely solely on the physician's determination documented as a screening or a diagnostic procedure. Thank you.
So our ask from you guys today is the following. We'd like you to share this with the administration, providers, schedulers, coders, endoscopy leadership, and again, your providers, really important. And use this information to direct correct coding quality and process improvement projects within your organization. And then monitor and internally audit this periodically to make sure that we're getting it right at the hospital level with the entire ecosystem of coders. I want to thank Jennifer Hutchinson with Baptist Health for the coding consulting, and I want to thank Deb Campbell with the KHA for putting this together. And finally, I want to thank Amanda Smart, our executive director. We want to thank you for attending this. And again, this is the recorded version of today's presentation that was presented live to the Kentucky Hospital Association earlier this year. Thank you very much.